Thank you very much, Naji, for inviting me. Thank you, everyone. So let me just share my slides and so I hope you can see my slides. Thank you.
Yes, we can see. I can see them.
So Naji practically asked me to talk about alcohol and cognitive impairment. It's a spectrum. In that sense, is a difficult concept, ranging from one end to what we call Wernicke's encephalopathy, of course, with other clinical stigmata, and to the other end, relatively mild or subtle cognitive difficulties, mainly frontal lobe deficits, sometimes even described as a marker for relapse into alcohol cycle. Before I move on with my talk, so there is no conflict of interest to declare today. But I think it would be interesting to talk through journey from history of psychiatry. Most of us will know about Karl Wernicke and Sergei Korsakov. We name two very well described conditions to them. So it's just a case description of kind of Wernicke's earlier case report. So 33-year-old former soldier who was heavy drinking and admitted with delirium tremens and died, unfortunately, relatively soon after first presentation. And that is when kind of Wernicke was able to then describe the stigmata of what is called Wernicke's encephalopathy. We know that from autopsy studies, we are able to identify structural brain changes associated with alcohol and what we now call alcohol-related brain damage. So in that sense, when we talk about cognitive impairment with alcohol, we are essentially talking about a form of brain injury. But as we all know, clinical life is a little bit more complex than a single description, and I will talk about it later in my talk. So this is Sergei Korsakov's case series description, consisting of 30 people with alcohol-related problems and 16 non-alcoholics. That's how it has been described. And the syndrome that was described as psychosis polyneuritica and typical memory deficits in conjunction with polyneuropathy. We know that people who are described to have Korsakoff syndrome show severe impairment of current and recent memory. And memory deficits occurring in clear consciousness, differentiating it with Wernicke's encephalopathy. But when we look at the case series description in more detail, we know that the prodromal features described were very close to what was described by Karl Wernicke's. And then confabulation, when people are able to include new information for inaccessible parts of their memory. So I did briefly refer to alcohol and structural impairment. So kind of we know now through postmortem studies, we know now through kind of neuroimaging studies that people with prolonged alcohol use, evidence of cognitive impairment, evidence of vitamin deficiencies, uh, kind of they do present with a number of now well-recognized structural changes. We also know that for some of these people, abstinence does allow recovery not only of function, but when we rescan them, then we see kind of volume loss being restored to some extent, for example. So the area that were described by Wernicke's in Wernicke's-Korsakoff syndrome are typically kind of lesions in periventricular gray matter, fourth ventricles, and atrophy of mammillary bodies. But in clinical presentation, how many people with neat Korsakoff syndrome we do see? I have seen few. I see lots of patients. I'm a practicing clinician. But not that many. Usually you see mixed presentation, mixed presentation associated with vascular risk factors, mixed presentation having additional comorbidity, psychiatric as well as physical health. People having evidence of cirrhosis of liver, people having evidence of a stroke, for example, or people with history of falls presenting with a superimposed subdural hematoma and adding to the brain injury or brain insult. What is very important to recognize that a lot of people present with frontal lobe features. Okay. And it is the frontal lobe features that are now recognized as relapse marker for alcohol relapse. So if you are seeing a patient with cognitive impairment in the context of alcohol use or excessive alcohol use, is not only that they are risk of progression, if they continue to drink, they are more likely to kind of relapse after a period of abstinence. And I think these are some key messages. So there are three kind of theories or hypotheses. Um, so my colleague and our PhD student that I share with Naji, kind of Vijay, he summarized very well for us. So the frontal lobe hypothesis and assumes that actually most of the insult occurs in the anterior part of the brain or the frontal lobes, and having an impact on problem solving, abstraction, working memory, attention, and response inhibition deficits, impulsivity. And then there is a lateralization hypothesis saying actually right hemisphere functions are more susceptible to neurotoxic effects of alcoholism. In clinical life, you see patients who have a combination of deficits. And when you are planning their rehabilitation in much more detail, then you have to look at how you are going to present clinical information, how you are going to offer particular therapies, and what type of environmental measures you are going to use and put in place to allow safe abstinence from alcohol. And of course, the third hypothesis is that cognitive deficits are much more kind of widely dispersed and not specific. And then when we go in the detail, then we know that a lot of people have kind of additional cardiovascular risk factors, comorbidities, and kind of pathologies that we call complex in nature. So we looked at it a few years ago, and then our Intermedical Royal College's Committee on Alcohol-Related Brain Damage kind of we approved that we are going to use the term alcohol-related brain damage rather than terms such as alcohol dementia or alcohol-related cognitive impairment only, giving the message that when you see cognitive impairment, there are usually behavioral concomitants that go with cognitive impairment. Cognitive impairment allows us to then converge to help people understand a clear message. And but then when we go in the detail and in terms of management planning, then uh, we have to look at complexities of dual diagnosis. We know that 25% of people presenting with ARBD will have evidence of secondary microvascular strokes related disorder or head trauma, as I've discussed previously. And then patients may have up to 3 simultaneous conditions resulting in cognitive damage. So cognitive damage related to alcohol, but cognitive damage associated with uh, uh, metabolic issues or vascular pathology, cognitive deficit related to head injury. So as I did say, ARBD is an umbrella term, and it allows us to look at a wide-ranging clinical problem, but under one umbrella. There are 2 seminal features, so prolonged cognitive impairment and a causative link to excessive alcohol ingestion and thiamine deficiency. This is reference to CR 185, the guideline that we published through Royal College of Psychiatrists in collaboration with other medical Royal Colleges. Few years ago, I had a discussion with the editor of the guideline yesterday, and we are aspiring to kind of revise the guideline, hopefully, and start the process soon. Okay, so kind of there are some key lessons. First is the clinical profile of these patients is different. Kind of they're younger patients and sometimes less cognitively and functionally impairment and functionally impaired. And that is why sometimes it's easy to miss them in clinical settings. So if somebody is talking about some memory difficulties or you suspect memory difficulties, and if there is alcohol related problem, it is worth conducting a cognitive assessment, at least for it to act as a baseline kind of at a later stage. We know that services for patients who develop cognitive deficits in the context of alcohol are probably not fit for purpose or appropriate. We know that these patients do not engage well with alcohol relapse prevention programs. We know that their cognitive deficit or the functional frontal lobe deficit may be a marker for relapse. So they are a high risk group. But now we also know that actually with significant and appropriate input, the prognosis is reasonably good. Up to 75% of affective individuals improve with the right treatment, with the right framework of services in place to help them. So a key message from talk today is that we need to move out of that hopeless prognosis framework into a framework that it's probably difficult to organize services around these people. So it's a function of organizing services rather than the prognosis being poor. And that allows us to kind of look at things in more detail. So Vijay Delafon kind of kindly allowed me to share this data with you today. It is from his PhD thesis, and he's hoping to submit it for publication very, very soon. So it's not for kind of further circulation at this stage. So when we look at the systematic review of available literature, looking at studies that are community-based, as well as studies that are based on, that are called post-mortem studies, then the estimate is that there are probably 4 people with alcohol-related brain damage per 1,000 population. Okay, so then we applied it to population in Kent, but applied it to population in Kent that is more likely to present with alcohol-related brain damage. So, or you can say as a high-risk population, so 30 to 64. And the conservative estimate would extrapolate that there are about 2,872 individuals if we look at and accept that it's 4 per thousand, and much more if we accept the postmortem study findings that it's actually over 10,000. So it's a big clinical problem. So few words on principles of assessment. So you do your cognitive assessment still within the context of person's whole health. And of course, assessment is directed by the setting. You also assess for degree of functional impairment, because sometimes cognitive assessment alone does not give you reasonable indication of that how that person is functioning in his or her day-to-day life. And it's important that we check for underlying frontal lobe dysfunction and also mixed mood state that are relatively more common in this patient population. It's sometimes treating their mixed mood state that allows them to engage the patient in any meaningful rehabilitation program. And again, past treatment, you are talking about a group that has high risk of Wernicke's, evidence of head injury. So do check history of seizures. Do note physical health status, living condition, and social isolation. That's fairly common in this patient population. Professor Heather Gage at our previous meeting, she did talk about cognitive damage and homeless in individual, and I believe the study she was referring to was conducted in Sussex. And then, of course, awareness of any sensory or motor impairment. I was so pleased to hear the last talk on with focus on sensory impairments. I think it's essential that we are able to have a clear assessment of how a person is presenting. And of course, so important to be able to understand any cultural or diversity kind of related issues. One slide very quickly, just a reminder that this patient group is at high risk of developing Wernicke's encephalopathy and further complication. What is very important is that if you are considering alcohol detoxification, then follow good principles of how to reduce toxicity of alcohol withdrawal. You all know that, but a reminder account is given in CR 185 that I referred to in the previous section of my talk. And this is just kind of as a reminder that malnourished and unwell, and there are some people who will need prophylactic parenteral treatment using high-dose thiamine or Pabrinex for several days. So then again, people who you see who have long-term established Korsakoff-like presentation means presenting with very clear and defined memory impairment, as we have discussed previously. Then maintain abstinence, ongoing treatment with thiamine. But our experts from addiction faculty, they tell us that if we are to use acamprosate or oral naltrexone in combination with an individual psychological intervention, that they are of great help. And they do not add to the cognitive burden. So they are safer medication to use in this patient population to maintain abstinence in the community. The discussion with my colleagues in Northern Ireland, they tell me that their patients with alcohol-related brain damage and in long-term care, once they were discharged and then once they stopped their acamprosate, actually the relapse rate were higher in comparison to people who continued their acamprosate kind of in the community. So kind of some lessons. So just a reminder about cognitive assessment and care planning. What instruments do you use and when do you conduct cognitive assessment? So, Edinburgh's cognitive examination, kind of ACE3, Montreal cognitive assessment, what we call MOCA, they're relatively easy uh, and time efficient ways of establishing a baseline and monitoring progress. Yes, for some patient, detailed behavioral assessment and mental capacity assessments will be required, and I think that you need to keep in mind. The assessment points after withdrawal, considering that you are uh, kind of uh, going for a safe withdrawal, after 3 months of abstinence, and subsequently every 6 months until an optimum level of independence is achieved. So that's the general guidance. Uh, I think it's important that we are able to give out a message that prognosis is not hopeless. Actually, prognosis is quite good if there are appropriate services in place. So we need to revisit issue of commissioning of care, especially with the new integrated care systems. Uh, and CCGs that are covering wide areas. I think it's important to look at system and important to be able to give out message that appropriate services for this group of patients actually reduce hospital admission days, because these patients are admitted to psychiatric or physical or general hospitals again and again, and they occupy beds for longer periods of time. Appropriate services will reduce admission bed days, and that is how you actually achieve efficiency or cost savings. So then it's important to use strengths of established services, or a residential rehabilitation model for some patient. And I have told colleagues previously, and there is a very good team in Viral, for example, a dedicated alcohol-related brain damage team in the community that coordinates and link different services for these patients. Uh, just as a reminder that in certain settings, you are more likely to see somebody with alcohol-related cognitive impairment. Present service is one. Acute has hospitals, both psychiatric and general hospital. Of course, specialist units like liver units, uh, orthopedic units, community alcohol services, and of course, patient admitted to inpatient alcohol for inpatient alcohol detoxification and more long stay rehabilitation services. What outcome measures you can use to monitor progress? Again, I briefly talked about MOCA and ACE3, but then we know that sometimes we need to conduct a few more frontal lobe assessment tests, so frontal assessment battery. And for behavior, HONOS ABI has been recommended by Faculty of Neuropsychiatry at the Royal College of Psychiatrists. Again, as a reminder, use these outcome measures after withdrawal from alcohol, after 3 months of abstinence, and subsequently every 6 months until you achieve an optimal level of independence. Uh, so some key lessons. So cognitive state is likely to improve in a few weeks after 3 to 6 weeks of abstinence. Recovery appears to level off after that period, but then small gains continue. You have to then consolidate these gains, then uh, incorporate some rehabilitation strategies and environmental strategies in your care plan to achieve optimal level of independence. But we know that there are other areas of cognitive function and behavioral presentation that may take up to 2 to 3 years to resolve. Generally, we know that verbal recall deficits appear to resolve early, but more finer skills such as memory, abstraction, and perceptual motor skills may take a year or more. frontal lobe functions may take longer. And that gives us a realistic prognostic indicator in terms of how we monitor progress. Patients with additional pathologies, I talked about comorbidities previously, such as patients with stroke and head injury, may show limited improvement. Thank you very much.